As our society grows increasingly diverse on local, national, and global levels, it's essential for healthcare professionals to intentionally focus on cultural diversity, sensitivity, humility, and competency. This focus brings a variety of factors and considerations, which we'll explore together in this lecture. So, some key concepts before we proceed that are going to be absolutely fundamental in understanding diversity. First and foremost is going to be culture. This refers to the collective attitudes, customs, beliefs, and history that distinguish one group of people from another. It's transmitted across generations through art, language, objects, rituals, and institutions. Cultural diversity reflects the variety and differences in cultures within organizations, institutions, practices, communities, nations, or the world at large. Cultural competency, this means that a counselor operates within a comprehensive understanding of the outcomes and beliefs of another culture. As outlined within the ACA Code of Ethics, counselors are required to continuously enhance their cultural awareness to ensure competency and avoid unethical practices. Humility. This involves the ability to honestly assess oneself, including recognizing one's limitations. This requires a deep reflection on personal values, beliefs, and attitudes, as well as an acknowledgement of knowledge gaps. Normalizing these gaps is essential. What matters most is how we address them. Remaining encapsulated in one's dominant culture can be limiting. Instead, counselors must strive to expand their perspective and enhance humility. Cultural humility is a lifelong process of self reflection and self critique. It empowers counselors to engage meaningfully in interpersonal relationships, fostering mutual respect and embracing dynamic diversity. Cultural sensitivity refers to a counselor's willingness to adapt their behavior and communication to align with the client's culture and norms. While these concepts overlap, each is distinct in its focus and application. Together, they form a holistic approach to understanding and engaging with diverse populations. By examining both individual components and their collective impact, we can deepen our understanding and improve our ability to serve diverse communities. Here, I want to do a brief exercise with you. I have some photos up on this slide, and I want you to think about your perception of each person when you see a photo. Do you think of this person? So, first, we'll start with the woman in the middle. She's wearing a business suit. Do you think that she's hardworking, trustworthy, or manipulative? Next, let's look at the woman with the blue hair. Is she hardworking, trustworthy, or manipulative? Go with your gut reaction. How about the gentleman in the black? Is he hardworking, trustworthy, or manipulative? Do the same thing with these other photographs. Implicit bias is something that all of us possess, and your initial reaction to each of these photos reflects your learned implicit biases, and much of these are formed before we even turn 10 years old. Life experiences shape how we think, believe, and act, and that influences whether we perceive someone as hardworking, trustworthy, or manipulative. For instance, when you see the photo of the veteran, did you assume that he was homeless? Or perhaps maybe he's just an individual and he's not homeless at all. These first impressions are driven by implicit biases. See this photo of the veteran? He's got a little note in his hand. Thank you for seeing me as a veteran and not as a homeless person. This statement captures the essence of why counselors must strive to be non judgmental. Trust is the foundation of our work, and building trust requires commitment to cultural competency and awareness of implicit bias. Implicit bias occurs when we unconsciously hold attitudes or associate stereotypes with others. For example, we may unknowingly harbor negative stereotypes about individuals without even realizing it. Recognizing and addressing these biases are going to be ongoing tasks that you're going to carry with you throughout not only this program, but your entire career. Self awareness and continual self reflection are critical for personal and professional growth in this area. To develop ethical and multicultural competence, it's essential to cultivate an awareness of how our personal cultural attitudes, values, beliefs, biases, and assumptions shape how our perceptions and interactions. You may feel that you are already familiar with your own values and biases, but I really encourage you to dig deeper. Often, our initial impressions and behaviors stem from deeply ingrained implicit biases and understandings. Subtle influences that may not be easy to articulate or to recognize. These biases are often shaped by life experiences and evolve over time, becoming part of our everyday language, behaviors, and thought patterns. I challenge you to critically examine these personally held values, biases, and assumptions. Doing so not only enhances your self awareness, but also expands your ability to understand and engage with diverse populations. This process requires a genuine willingness to learn and to remain open to cultural values, beliefs, and assumptions of others, particularly as you work with individuals from diverse backgrounds. While each individual is unique in how they think, feel, and behave, cultural norms often influence groups in very meaningful ways. To serve our clients effectively, we must also integrate culturally appropriate and evidence based individual and systemic interventions. This involves reflecting on the practices that we use, our counseling style, approach, and interventions, and asking whether they align with the needs of the individual in front of us. Are our methods rooted in rigid theoretical orientation, or are they drawn from a diverse, adaptable toolbox that can meet the unique needs of each client? Achieving cultural competence requires flexibility, intentionality, and a commitment to tailoring our approaches to honor the diversity of the individuals that we serve. Cultural competence also encompasses the ability to communicate effectively in ways that are culturally appropriate. Miscommunication can often arise from differences in language, as well as verbal and nonverbal behaviors. For instance, think about eye contact or physical space between you and the client during a session. What feels comfortable for you may not be culturally appropriate or comfortable for the client. These nuances must be acknowledged and navigated thoughtfully. Additionally, explicitly outlining the expectations of the treatment process is going to be essential. Clients entering treatment may be unfamiliar with the counseling process, and it can feel very vulnerable. While seasoned professionals may operate on autopilot with established routines, ethical standards, and day to day practices, clients who do not share this familiarity, it can be very crucial for us to clearly communicate what they can expect from the treatment experience and what their role is going to be throughout the process of us working together. Cultural competence also extends to test administration and interpretation. We're going to talk about this more in another lecture. But when we use assessment tools, we need to consider whether the test has been normed and if so, on what population. Historically, many tests have been predominantly normed on white male populations. Relying on these tools when working with diverse populations really risks inaccurate interpretations and diagnoses, which can then lead to inappropriate treatment plans and referrals. A critical growth area in this field of is to develop more inclusive, culturally sensitive tools that are normed with diverse populations in mind. Counselors must exercise caution in how they interpret and use assessment results, as these findings directly influence diagnoses and treatment protocols. Misdiagnoses or culturally insensitive conclusions not only hinder progress, but also fail to meet the ethical obligations to provide appropriate care. Similarly, cultural differences in expression or behavior may appear to align with DSM diagnostic criteria, but these expressions may be culturally normative rather than indicative of a mental illness. Research also plays a key role in enhancing cultural competence, although significant gaps remain. For example, there is limited research on the intersection of religion, culture, and suicide risks. While these gaps highlight opportunities for growth, there's also an abundance of research that can deepen our understanding of cultural competence in diverse populations. Counselors are encouraged to explore these areas they are less familiar with, especially when implicit biases and stereotypes surface. Engaging with research in these areas allows professionals to challenge their assumptions and expand their knowledge and provide more informed and effective care. Ethically sensitive providers are aware of their own limitations and knowledge and skill and take action to address these gaps. When these limitations arise, it's important to seek supervision, consultation, and additional research to deepen your understanding and develop greater cultural competence. This process is often referred to as second order growth, and it involves continually learning, accommodating new information, and integrating that into practice to improve effectiveness with diverse outcomes and diverse populations. Being culturally competent also requires being open to transparent, safe conversation with clients about ethnic and cultural values. One of the most effective ways to understand a client's experience is by asking them directly. Encourage clients to share their unique perspectives, challenges, and ways that their cultural background has shaped their identity. This approach not only fosters understanding, but also highlights the resilience and strength that stem from their cultural heritage. It is equally important to remain open to multicultural differences and to recognize when feelings of resistance or discomfort arise. Such moments present opportunities to reflect on potential countertransference and explore your own reactions to better serve your client. Providers should also be prepared to connect with clients and cultural resources. Familiarize yourself with culturally relevant services and organizations in your community. Maintain a resource binder with a dedicated section for cultural resources. This will be very, very helpful for your folks. These resources can offer clients access to ancillary services that are sensitive to cultural needs, fostering mutual understanding and support in ways that may not be possible within other cultural contexts. As we continue, it's important to highlight the significant correlation between culture and suicide, which is why suicide and self harm are integral components of this module. I'd like to take a moment to discuss suicide assessment and share some key facts regarding suicide assessment rates. Now, data is all coming from the CDC. So, when looking at the United States, when it comes to suicide death plans and attempts, over 49,000 people died in the United States by suicide in 2022. Now, the data is always going to be a little bit behind compared to the year that we're currently in, just because it takes a while to gather all of the data and analyze it. But this evens out to about one death every minute. Excuse me, this equals out to one death every 11 minutes, which is very significant. Many adults think about suicide or attempt suicide. So, as we can see here, 13.2 million seriously thought about suicide, 3.8 million made a plan for suicide, and 1.6 million attempted suicide. Here we see a graph, and this shows us that suicide rates have increased 37% between the years of 2000 and 2018. So you can see that steady incline there. And then it decreased 5% between 2018 and 2020. However, the rates did return to their peak in 2022. When we look at gender, the suicide rate among males in 2022 was approximately 4 times higher than the rate among females. And males generally make up 50% of the population, but they make up nearly 80% of suicides. So that's very, very significant and important for us to take into consideration. And lastly, some groups have disproportionately high rates of suicide, and that's why we're talking about it in this particular module whenever we're talking about cultural, various different sensitivities and diversity. So, as you can see here, we have very high rates when it comes to non Hispanic, American Indian, and Alaska Native folks. Then, as we continue to move down, we can see various different other populations. The second most the highest rate of suicide is going to be non-Hispanic white folks. And then as we move down, non-Hispanic Native Hawaiian or other Pacific Islander, continuing to move down, non-Hispanic multiracial, non-Hispanic Black, Hispanic, and then non-Hispanic Asian. So you can see that it's going to be very important for us to look at various different groups, as we can see that there are some groups who have very, very disproportionately high rates of suicide. And what do we do with that in the counseling sessions? So let's delve further into the language around suicide and how we can approach this topic with cultural competence and sensitivity in our communication. Understanding the nuances of language is critical, especially when working with diverse populations where cultural factors may influence how suicide risk manifests or is expressed. Suicidal ideation refers to thoughts about wanting to be dead or active thoughts about ending one's life. These thoughts may or may not include a specific plan. It's important to note that suicidal ideation can be fleeting. For example, I've worked with individuals who initially express statements such as, I want to kill myself. However, when we explore this further, they've clarified that they did not truly intend to end their life, So, this highlights the importance of really asking questions, assessing the intent and the plan and the means. Often, such thoughts are situational, driven by severe stress or behavioral factors that do not indicate a formally formed plan or intent to act. When assessing suicidal ideation, it's going to be critical to explore. So, first, we want to ask about intent. Does the individual genuinely intend to end their life? Plan. Is there a specific plan in place? Do they have a time, a method? Do they have the means? Does this person have access to the means to carry out that specific plan? In addition, we must assess gestures, time frame, and risk factors. For instance, individuals with a history of previous suicide attempts are at a higher risk of completing suicide in the future. However, the absence of prior ideation or attempts does not mean that the current situation should be minimized. Each individual's risk profile and situation are unique, requiring a thorough and ongoing assessment of intent, plan, means, and ideation. We need to be transparent in these conversations, which is going to be absolutely vital. We must not shy away from asking directly about questions. So we may say things like, are you having thoughts of killing yourself? Are you having thoughts of self harm? Are you thinking about hurting someone else? We also need to recognize the acts of furtherance, which signal the progression from ideation towards action. Some examples include researching methods or creating a plan, gaining access to means, acquiring a weapon or medication, or aborting previous suicide attempts. Now, I want to make a note here because a long, long time ago, I was in your shoes, and I remember learning how to answer the phone at our community clinic and being instructed to ask folks directly about if they were thinking about suicide, if they were thinking about killing themselves. And I remember being very nervous about using those types of language and asking so directly. And I remember asking my mentor at the time, hey, if I ask these questions and this person isn't thinking about suicide, am I going to put these thoughts in their head? And the research and what my mentor told me was no, that's not the way that this works. In fact, when we ask directly and we use the word suicide, that in fact, that is the best practice for us to do is to act and to ask directly instead of kind of beating around the bush with our language, such as, are you thinking about ending it? Are you thinking about checking out? Those are not going to be the best practice. Instead, we want to ask directly. So, again, I remember being in your shoes and being very nervous about asking the individual directly and using the word suicide. So, I just want to acknowledge that you may be there. You may be in that same situation that I was many years ago. And I want to put your mind at ease. So let's look at the last piece here, which is passive death wishes. Often these are fleeting suicidal thoughts where the individual kind of fantasizes about death without a clear plan or intent. For instance, someone may say, if I were hit by a car, I wouldn't care. It would be okay if I didn't wake up tomorrow. My family would be better off without me. Those are some of the statements we may hear. And passive death wishes may also manifest in risky behavior, such as driving under the influence, not wearing a seatbelt, engaging in other reckless activities. And these behaviors reflect a decrease in inhibitions and an increased risk that should not be ignored. As clinicians, our responsibility is to act with the client's best interest, ensuring their safety and well being at all times. While such expressions may sometimes be situational, they always warrant careful evaluation, transparent communication, and appropriate intervention to safeguard our client. Next, we need to talk about protective factors. So, when we're assessing suicide risk, it's essential to evaluate both protective and risk factors. So, first, we'll start by talking about protective factors. And this is various different elements that provide stability and hope and meaning in this individual's life. These could include positive social networks, people who support them in their life, people who provide emotional and practical support. Maybe that's spirituality. Does the individual have a spiritual belief system or connection that offers comfort or meaning? What in their life gives them significance? This could be family, children, pets, a sense of responsibility that they feel towards others. Do they have sources of satisfaction in their life? Are there activities or hobbies that bring them joy or fulfillment? If they respond that nothing currently brings them satisfaction, explore what used to. Consider how you can support them in reconnecting with those sources of joy or meaning. Adopting a future oriented approach is going to be vital. Encourage the individual to reflect on goals or possibilities for the future, as having the ability to envision a future significantly lowers suicide risk. A trauma informed care approach is going to be one of our best tools for providing safety and fostering hope. And this involves addressing a couple of key factors, first of which is safety, continuously assessing the individual's sense of safety and work to create a therapeutic space that is safe. Emotions, understanding how the individual expresses and manages emotions. Loss, recognizing areas of loss in their life, as loss brings significant change that can impact mental health. Future orientation, help the individual look ahead and focus on the potential for positive change in the future. Other protective factors may include positive coping skills. Does the individual have any healthy ways of managing stress or adversity? Problem solving abilities. Are they able to engage in effective problem solving when faced with challenges? Additionally, the therapeutic relationship is going to be the cornerstone of suicide prevention. A strong, trusting, caring relationship with you or another clinician or a support person can provide a critical sense of connection. If you're new to working with this individual, consider identifying someone within the agency that maybe this person already has an established relationship with to enhance support. Ultimately, the goal is to draw from these protective factors to create a foundation of safety and hope, helping the individual build resilience and reduce their risk. Now we're going to move over to risk factors, and this may include several critical considerations. And risk factors may signal imminent danger or require immediate attention. So, suicidal ideation, if the person expresses current thoughts of suicide, intent to follow through, a specific plan, access to means, the risk is going to be exceptionally high. For example, if someone states that their plan is to end their life by shooting themselves and they have access to firearms, this is a high risk situation requiring urgent safety measures. What about previous suicide attempts? A history of prior attempts significantly increases the likelihood of future attempts or completion. Substance use can exacerbate mental health conditions and may lead to co occurring issues. Also, substance use is going to lower inhibition and may lead to poor judgment. Post acute withdrawal symptoms can heighten depressive and suicidal thoughts, further complicating the situation. Psychiatric history, a current or past diagnosis of mental health condition, is another significant risk factor. Additionally, if individuals have been discharged from an inpatient psychiatric care, are at particularly high risk within the first 30 days post discharge. This is often a critical period that warrants very close monitoring. Impulsivity or poor self control. Individuals with difficulty managing impulsive behaviors are at greater risk, particularly when combined with feelings of hopelessness or helplessness. Significant loss or grief. Recent losses, ongoing bereavement, or unresolved grief can increase risk. Family history of suicide. A history of suicide within the family can be a contributing factor. History of abuse, such as physical, emotional, or sexual, may elevate risk. Concurrent conditions, so mental health diagnoses combined with other conditions, such as substance abuse, can increase the overall risk. And demographic factors and cultural factors. So, risk can vary based on age, as we saw in the previous slides, gender, race, ethnicity, culture, religion, and sexual orientation. So, providers must be familiar with how these factors uniquely influence risk in different populations. Now, we've got a couple of assessment tools, and these are standardized tools that can provide us with some very valuable information. The first we're going to talk about is the PHQ 9, which stands for Patient Health Questionnaire 9. It is a widely used measure of depression severity. It includes a question addressing suicide risk. So the higher the score, between 20 and 27, suggests severe depression and increased risk for suicide, necessitating a more intense intervention. For individuals with subclinical scores as low as 3, interventions may focus more on prevention and support. We also have another related questionnaire, the GAD 7, which stands for Generalized Anxiety Disorder 7, and it is often used to assess anxiety levels. But this, again, can still provide some very useful insight into how anxiety may contribute to suicidal thoughts or behaviors. Ultimately, risk factors must be evaluated alongside protective factors to develop a comprehensive understanding of the individual's unique circumstances and tailoring interventions to their level of risk to ensure a more effective and responsive approach to safety and care. Next, we need to talk about self injurious behaviors. When assessing individuals who engage in self harm, it's important to recognize that self injury does not always indicate suicidal intent. While the two can sometimes be related, they are not inherently linked. Therefore, it's crucial to differentiate between these behaviors and understand the individual's experience. Self injurious behaviors often involve intentionally harming oneself and are most commonly linked to attempts to manage or control pain. Oftentimes, in work with adolescents, they engage in self injurious behavior as a way to cope with overwhelming emotions or to help regain control over a difficult situation. This act of self injury maybe is cutting with a metal part of a pencil eraser can hold significant emotional meaning for that individual. And it's important to explore what the person is enduring in order to better understand their experience in terms of safety. And we can be proactive in creating an environment that reduces risk, which may include removing objects that could be used for self harm to minimize the potential for injury. And lastly, here we're just going to wrap it up. Overall, it is important to consider how culture can influence suicide risk. Additionally, we must recognize our ethical responsibilities and the need for cultural competence in this area. As you continue to work through this module, you're going to be prompted to explore these concepts more deeply. And I encourage you to develop a greater awareness and reflect on the areas that you may have implicit biases, where you may feel most challenged by diverse groups, or where you have limited awareness. By examining the relationship between culture and suicide, you can strengthen your responsibilities of ethics and cultural competence in this area. Very lastly, I want to take a moment to talk about a training that I recently went through. It's called ASSIST, Applied Suicide Intervention Awareness Training. And this is a 2-day program. If you have the ability to join in on ASSIST training, I highly recommend it. It helps you to understand and listen to an individual who may be talking about suicide, but very indirectly. So it helps you understand those what we call invitations. Then it helps you to ask questions to understand the individual story, to help pull out protective factors, and then to engage them and talk about self safety moving towards life. And so, again, if you have the opportunity to sit in on an assist training, I highly recommend it. All right, that's all for today's lecture. Thank you so much for your time and attention.